Well, good afternoon, everyone. I'm delighted to be back and look forward to sharing some summary slides with you regarding this very controversial topic. So, we've taken a meandering road from then to now regarding breast cancer. It was one disease, and now, of course, it's many. We've gone from simply breast cancer to ER plus ER negative disease, into a grouping of 4 subtypes based on HER2 positive or not, and then into an era where we thought about ER plus disease as high-grade low ER level or low-grade high ER level, then into the multigene assay and molecular intrinsic subtype era, and now, of course, whole genome and next-gen sequencing. For years, chemotherapy was not deemed to be effective or as effective as an ER-negative disease, but the most recent iteration of the Oxford Overview suggests that all benefit from chemotherapy with ER plus HER2-negative disease, including older women. And this is just one slide from the Lancet publication of the chemotherapy update, where regimens were recategorized into anthracyclines, the best anthracycline or CMF regimens, plus endocrine therapy versus endocrine therapy alone. And as you can see on the left, for younger women as well as for the older group, there was a nearly identical reduction in recurrences over 10 plus years with the addition of chemotherapy to endocrine therapy versus endocrine therapy alone, leading at least Sir Richard Peto and his colleagues to state that all women benefit from chemotherapy. They looked at this a bit further in the publication, as Angelo DeLeo outlined for you the other day, and could not find a subset, at least by ER level as measured in femtomoles per milligram, or age group or grade, that benefited differently, in other words, did not have a benefit from chemotherapy. However, that's not why we're here to just conclude that chemotherapy works the same for all, is it? We do know that standard factors can define bad stage or high recurrence risk, such as higher T stage, positive axillary nodes, or number of positive nodes. But these standard factors can be overruled by other biologic factors. That is, the high risk status is potentially overruled, meaning no chemotherapy is needed, by first, we've learned very high estrogen receptor levels. And 3 major phase 3 trials showed this quite nicely using different techniques, the SWOG study, IBCSG, and NSABP trials. Also, there have been hints from various single phase 3 trials that low-grade or well-differentiated tumors may not benefit as much from adjuvant therapy. Similarly, for low proliferative rate by Ki-67, and then more recently, low 21 gene recurrence score Oncotype assay, or a good risk 70 gene mammoprint signature, and then the LUMINAL A intrinsic molecular subtypes have been posited to similarly predict whether chemotherapy works or not. So since that's in the title of my presentation regarding the subtypes, I'm going to start there first and discuss what we do know regarding the ER plus chemotherapy controversy from the intrinsic subtype data. And you're all well aware of these subtypes, and outlined in red at the bottom is the group that I'm addressing, the LUMINAL the luminal signatures, the subtypes LUMINAL A and LUMINAL B, coming from the differentiated luminal cells. After intrinsic subtyping was published by Chuck Peru and colleagues, another group with Parker and Matt Ellis and Chuck and others went on to show us that from paraffin material, the PAM50 assay could determine intrinsic subtypes from paraffin blocks. Now, highlighted in red on the upper right for the ER plus clinical group, you can see that the intrinsic subtypes are present in these patients with differential outcomes. So what you think may be ER plus could contain a number of the subtypes in a given patient sample. So what does define LUMINAL A and LUMINAL B? These definitions are variable, they've evolved, and there are inconsistencies, as you heard in both Drs. Peru and Pusztai's presentations. We have the original cDNA method, modifications of that as well from frozen tissue. Then the PAM50 from paraffin, the PAM50 ROR score, RORS, and ROR proliferation. And then leapfrogging beyond all of that was the St. Gallen 2011 single variable IHC shorthand and other IHC algorithms. These IHC definitions have been inconsistent across the various publications. Some involve ER and HER2 only, others add grade, differing definitions of grade, others add PGR or not, others Ki67, and different cutoffs of that, and then local or central assessments are used. The single binary factor IHC is not closely concordant with either the 21-gene recurrence score Oncotype or the 70-gene mammoprint assays, and I'll touch on that in a bit. So, what about the molecular intrinsic subtypes and the prediction of chemotherapy benefit in ER plus HER2 negative disease? I call your attention to an outstanding editorial by Dan Hayes published last year in the JCO, and this is one slide from his editorial, and his title of the slide, that there is a theoretical spectrum of sensitivity to adjuvant systemic therapy by intrinsic subtypes, meaning that there are no prospective data that tell us that these subtypes are predictive using the rigors of these types of analyses in phase 3 trials with endocrine therapy alone controls. But in order to allow us to improve upon our St. Gallen 2009 recommendations at the meeting in 2011, we changed our consensus to use intrinsic subtyping as a way to select which therapy should be given optimally in our patients. And from that publication, we have the luminal A's were defined by IHC binary scoring single variables into ER and or PR plus, HER2 negative, and Ki67 low for the luminal A's, and Ki67 high for one subset of the luminal B's. And then using the shorthand subtyping, recommendations were made as shown here, which you're all familiar with, as published in the Annals of Oncology. And I will come back to this at the end with some suggestions for improvement and enhancing what we published 2 years ago. We do not have any prospective data or any predictive data really of the cDNA original intrinsic subtyping for chemotherapy benefit, but we do have data with the PAM50, and this is from the publication of Parker et al. Looking in panel B, where you can see as circled that there are either no or very few pathologic complete remissions to TFAC chemotherapy with a very low risk of recurrence score using PAM50. And then from Chuck Peru's lab, these data were presented at San Antonio in 2011, outlined in the red rectangle for luminal A and luminal B, using the PAM50 subtyping and adjusting for clinical grade, T status, and nodal status. The pass CR rate was only 3% for luminal A's versus 16% for luminal B's. But we do have a bit more data that's emerged for selecting the type of adjuvant chemotherapy, meaning you've already decided to give it. These 4 trials have been looked at in different ways for the predictability of the luminal category. So first, using central IHC for ER and HER2, CLGB 9344 showed there was no benefit to adding paclitaxel after AC versus AC alone if ER positive, HER2 negative. Then in BCIRG 001, using central IHC for ER, HER2, and Ki67, there was no benefit to TAC versus FAC if ER plus, HER2 negative, and Ki67 low. Using PAM50 and NCIC MA5, there was no benefit to CEF versus CMF in either luminal A or luminal B. And then most recently, using clinical pathologic variables PAM50 and PAM50 proliferation score in GuyCam 9906, the benefit to paclitaxel after FEC versus FEC alone was only seen in the low PAM50 proliferation group. None of these other categorizations seem to make a difference. So, while molecular intrinsic subtyping by PAM50 predicts chemotherapy benefit in the neoadjuvant setting and perhaps can aid us in selecting the type of chemotherapy once you've decided to give it, there are no prospective predictive data yet applied to large adjuvant trials, unlike multigene assays. So the multigene assays you're all familiar with, these are just 3 of them. There are many other prognostic signatures. All of them give us a high-risk category driven by proliferation genes, which tell us relative endocrine resistance or relative chemotherapy sensitivity. But only the 21-gene recurrence score Oncotype has been tested in phase 3 trials with tamoxifen alone controls in both node-negative and node-positive disease. Before I summarize those data, I do want to highlight that there is a recurring discordance between the risk level assigned by clinical pathologic factors versus multi-gene assays in about 30 to 35% of cases. But when looked at, these multi-gene assays add independent prognostic information to the clinical pathologic risk assessed by Adjuvant Online or by single genes. Multi-gene assays may be more accurate predictors of outcome and treatment benefit in the individual patient, but what we are still looking for is a genomic plus clinical variable algorithm that will allow us to use both sides of the question. I think we have to wait till our big phase 3 trials complete to get those developed. But just a word real quickly, a few slides about the discordance. Here you see in this slide a sizable subset of high-grade tumors have low recurrence scores in NSABP B20. Or in the SWOG 8814 node-positive data set, you can see that whether by RT-PCR or the ER-ALRED score, you have a high percentage, not a high percentage, but a reasonable percentage of patients with high recurrence scores despite very high ER levels. And then most recently in the Plan B trial, there was a poor correlation between single IHC markers within the LUMINAL A-B designation and the recurrence score here for Ki67 highlighting the correlation coefficient is only 0.4. So there are a large number of patients with high Ki67s with low recurrence scores. And then using a combination of blueprint plus mammoprint to derive a LUMINAL A and B categorization, there was reclassification of 18 out of 72 patients with ER plus HER2 negative disease by standard IHC into HER2 type or basal type, and these data are presented here at these meetings by Dr. Whitworth and colleagues. So what we know then regarding prediction can be summarized on the next few slides. For the 70 gene expression signature mammoprint, we've known, as outlined on the left, that within the St. Gallen high-risk designation, there is a good risk signature that has a very good outcome over many years. Translating into a population non-randomized analysis, those patients with mammoprint low risk did about as well with chemotherapy or without it. Again, treatment was selected by the physicians. And thus, we are all awaiting the MINDAC trial results, hopefully next year, regarding whether clinical pathologic factors or the mammoprint assay optimally allows you to select therapy. The 21-gene recurrence score assay Oncotype is strongly predictive, as you know, in NSABP B20, with the high scores benefiting from chemotherapy. But what we forget from this publication is that there is a very significant interaction of chemotherapy treatment with the clinical and gene expression variables in B20, with significant interaction for the recurrence score, but not for ER level, grade, tumor size, proliferation genes, invasion genes, or HER2. And so we await also, we hope next year, the results of TAILOR-X to guide us in what to do with patients with the intermediate scores regarding chemotherapy benefit or not. Then in Node Plus disease, we showed in the Southwest Oncology group that with high recurrence scores, there was a strong benefit to CAF added to tamoxifen versus tamoxifen alone. When we look specifically at breast cancer-related survival events, over time, out to 10 years, there was about a 90% survival for either the chemo group or the non-chemo group with low recurrence scores. This interaction was significant. And this is probably the most important summary slide I can show you regarding these data with the Oncotype DX assay, that there's a remarkably similar significant interaction between the chemotherapy benefit seen in B20 in node-negative disease for 10-year distant relapse-free survival, and for 10-year breast cancer-specific survival in the node-positive SWOG 8814 trial. And just looking on the far right, you see the dramatic benefit to chemotherapy in the high scores versus the low scores for each trial. So the responder trial is ongoing to validate these data from SWOG 8814 in patients with 1 to 3 positive nodes and recurrence scores less than or equal to 25, where the randomization on the far right is to chemotherapy and endocrine therapy or endocrine therapy alone. We have accrued, registered of the 9,400 planned of over 2,000 and randomized by now over 1,000 patients to this question, so it is accruing quite well. One problem that we have to address that we do not yet know how to address, and we need trials to address this, is however you want to define the patient, high ER level, low proliferation, low recurrence score, good risk 70 gene, luminal A, what to do with the patients with high risk of recurrence, but this so-called favorable biology, in other words, the biology that does not respond to chemotherapy. And so on the left is the 8814 circled, those high-risk, many positive node patients, but low recurrence scores. And then the ATAC data showing a very similar risk of recurrence despite the number of the low recurrence score. I call your attention to an exquisite presentation by Dr. Picard at San Antonio, which you can watch on the web, regarding very small tumors, but how to select which patients require therapy. And as she concluded her presentation, this is her summary slide, the luminal subtype with high-risk genomic profile, even though tumors are very small, do deserve treatment with systemic chemotherapy. I mentioned the Parker and the Chung and Peru data when I talked about intrinsic subtypes regarding pathologic CR and prediction by PAM50. And those are the two not highlighted. The 4 highlighted in red are the data for multigene assays, for the 70-gene mammaprint or for the Oncotype DX. And the theme is identical in these trials. There are no pathologic CRs, or very few, in the good risk category for the genomic assay. So to conclude, this is my take on this controversy. Practically in the clinic, using just a clinical signature, a significant number of patients may be either undertreated or overtreated with chemotherapy. In the very low risk settings, biology still matters, and the use of standard single IHC variables can be misleading and can lead to avoidance of chemotherapy in patients who would benefit. So not all clinical luminal A's determined by single variable IHC are luminal A's, and the data are quite consistent across all the assays. In high-risk settings, biologic subtypes of ER+ disease differ in the degree of sensitivity to chemotherapy, predicted best, again, by a combination of factors and genes. The optimal approach includes multi-genome predictors for both luminal A and luminal B. The avoidance of standard chemotherapy due to relative resistance may be justified in higher risk HER2 non-enriched subgroups that are endocrine responsive with low proliferation. And this category is variably defined by low 21 gene recurrence score, luminal A, low risk 70 gene signature, but not consistently by IHC shorthand methods alone. The highest risk scenarios that also present with this biologic profile require alternate strategies to increase cure rates. And please recall Dr. Lajos Pusztai's summary statements from his talk yesterday, quoting, "Genomic prognostic tests do not just quantify ER, PR, HER2, and Ki67, but they combine these variables into a statistically optimal multivariate prediction model. Routine ER, PR, HER2, and Ki67 used in combination as binary categories are not the same as a, for example, centrally determined IHC score based on continuous variables for these factors or multivariate genomic predictors." So, panel members, tomorrow, can we improve on our 2011 statement regarding selecting the best candidates for chemotherapy in ER plus disease by enhancing the definition of the most appropriate biology? So going back to what I published, I think we need to look at what we published in 2011. I think we need to look at this IHC shorthand subtyping and enhance this by bringing in our genomic predictors, and also consider that some of the statements that we made may be no longer accurate, that I've highlighted in red, and I think we can all look forward to a very lively debate tomorrow on this question. And I thank all of you who've engaged in conversation with me, sent slides, and otherwise helped me think through these presentation thoughts. Thank you.